Well, thank you, everyone. It's really a pleasure and an honor to be here to present to you today. From the introduction, I'm going to talk to you about public health risks, some threats that we see on the horizon, and hopefully you'll enjoy this discussion that we'll have. What I'll talk about today are current public health threats, future risks, and some potentially high consequence events that we foresee, and policy and practice that we think can mitigate some of these risks. So current public health threats. To start, what do I mean by public health emergencies? As you all know, they're really any type of disaster or incident that has an acute impact on the health of the public at the population level. When you think about it, pretty much any type of major disaster, whether it's a wildfire or an outbreak of infectious disease, has significant public health implications. So these examples that you see here are all acute public health emergencies. They may also cause long-term harm, but the response to an acute event is time-sensitive, obviously, and leaders have to act quickly to save lives and prevent further harm. So what I'll talk to you about today is kind of the spectrum of types of public health threats, from natural to deliberate. Starting with naturally occurring threats. Over the last couple of decades, we've seen an increase in frequency of novel disease emergence. Since 2004 with SARS, there have been novel infectious diseases that cause significant illness in humans more than we've seen in the past. There have also been outbreaks or reemergence of infectious diseases that appear to are behaving differently than they have in the past. So I'll talk about a few examples of this in a minute, but I wanted to talk about first, what can these things be attributed to? Some of this is simply recognition. We are undoubtedly better at recognizing emerging diseases through public health surveillance, animal surveillance, than we have been in the past. Emergence of a novel, highly pathogenic avian influenza, for example, is detected fairly quickly nowadays and closely watched for spillover into humans. But better surveillance only accounts for some of these changes. In many cases, disease emergence and spread are related to densely populated areas, high mobility for people, as well as proximity to wildlife and agricultural practices that might create vulnerabilities for spillover into humans. Most emerging diseases are zoonotic, meaning that they originated in animals and then mutated to enable infection of humans. So when we have these close human-animal interfaces, say in wet markets where live animals are being sold, and you combine that with densely populated living in megacities, the conditions become much more ripe for new spillover events. We've seen over the last decade in the US and globally a significant expansion of vector ranges, so mosquitoes, ticks, those kinds of vectors. This is driven by a complex combination of things, but includes changing climate and also changing public health practices, which I'll talk more about in a minute. In addition, I have to mention that vaccine hesitancy and outright refusal are having important impacts on disease spread. And finally, antibiotic use is driving antibiotic resistance globally, which could return us to a pre-antibiotic age. So now I'll go into a few examples, and you may not be surprised that my first example is the novel coronavirus that is now circulating primarily in China. The virus is called SARS-CoV-2 because it's closely related to the SARS virus. This causes, obviously, human disease. The disease was also recently named. It's now called COVID-19, which is coronavirus disease 19. This is a novel pathogen, meaning that we haven't seen it before. There's no existing immunity in human populations to the virus in anyone except those who have been recently infected that we know of. This virus is the result, we think, of a spillover event, most likely from bats to an intermediate animal host that's yet to be determined. From genetic analysis and examination of the lineage of this virus, we think that this is a recent spillover event. This happened probably sometime late last year, maybe October or November. Originally, once this virus first emerged, the thought was that the spillover was linked to a wet market in Wuhan, China. That remains to be proven. One of the index cases, at least, has no link to that market. So that's still under investigation, but that's the going hypothesis. This virus is already highly adapted to infect people, and it's fairly efficient at spreading from person to person. We're still trying to understand how efficient this spread is, but it looks like it is going to be probably at least, or if not more, contagious than influenza. We think that on average, someone infected with the coronavirus, based on the data we have now, infects about 2 to 3 other people. This is what's termed in public health as the R-naught. By way of comparison, the R-naught for other diseases, for flu, it's about 1.7. For measles, it can be up to 18. And the R-naught for Ebola is about 2. This is an average, and it differs greatly depending on the setting, but we think 2 to 3 is about what we're seeing with this virus. One problem we're facing with this outbreak is that there is emerging evidence that people can spread the disease either before they develop symptoms or asymptomatically. They may never get symptoms once they're infected. So this will make it very hard to control because it will spread silently in many cases. Flu is somewhat similar in that you can spread flu about a day before you have symptoms of the disease, and you can also spread it after you've recovered. Right now, we think that this is likely to become a pandemic, the next pandemic. That said, to be a pandemic, a pathogen has to spread around the world, but pandemic status does not necessarily imply severity. We have had mild pandemics in the past. The 2009 H1N1 influenza pandemic was mild with a mortality rate of less than 0.1%. That's even milder than most seasonal flu outbreaks. In this case, we're still unsure how deadly this virus is. Experts are starting to converge on a mortality rate of about 2 to 3%, which is mild compared to some other diseases like Ebola, which is about 30%. However, on a global scale, you can appreciate that this is still pretty concerning. That would, eventually, if it is a pandemic, that would be many, many deaths. We're still very hopeful that this mortality rate will come down because, as I said, we're not uncovering all of the mild and asymptomatic cases that are spreading right now. So the more we learn about that, we think the mortality rate will decrease. The response to this outbreak so far has been totally unprecedented. Right now, nearly half of China's population is under some level of movement restriction in an attempt to contain the virus. A large percentage of travel has been temporarily halted, as has much of the travel internationally to and from China. These movement restrictions are both self-imposed by the Chinese government and also externally imposed by travel bans from other countries, including the US, and airlines canceling flights, either because they don't have enough people to fly in the planes or because they don't want to fly. There are some significant problems with this imposition of a fairly well-used public health measure, quarantine, but at this scale and with the draconian nature with which it's being enforced, there are concerns that we have. So we don't think it's going to be effective. People left the city of Wuhan before the quarantine was implemented. Quarantines in the past on this scale have never worked before. There are also serious concerns about human rights violations here. The restricted movement is not only controlling or attempting to control the virus, but also it's preventing people from getting basic necessities like food and medical care. That said, these measures may be having some impact on the epidemic curve that we're seeing now. The problem is that these measures cannot be enforced forever. Sufficient control over the virus in China has not been achieved through these measures. We're still seeing spread thousands of new cases every day. So when those travel bans are suspended, spread is going to continue. There are also huge economic pressures on China right now due to the coronavirus and the restrictions on movement. This is most recently and probably hits home for us most evidenced by Apple's announcement that earnings are going to be way down in the next quarter due to the coronavirus, the restriction of movement, the disruptions to supply chains. Moreover, we're beginning to feel the effects on supply chains in the US as well. China is a huge manufacturer of many medical supplies that we need and use here in the US, including masks. And where our hospitals now are starting to experience shortages in masks particularly, and that's just from this year's flu season, which is a little bit more severe than we normally see. So right now, political leaders and public health experts are facing some tough choices between continuing these efforts, which are very resource intensive, to monitor people coming over on flights, impose quarantines, and switching to a mitigation or a preparedness model to get our public health systems, our healthcare systems prepared to deal with the virus when it comes to the US. That might be a little bit of a bleak introduction to the topic this morning, but I just wanted to update you all, and as we go on, maybe in the question and answer session at the end, I'm happy to take any questions about the coronavirus. I also just wanted to show you this, which is some colleagues at Johns Hopkins have been tracking the cases and inputting them into this really valuable map, and it's a really great resource for understanding what's going on. The next topic I wanted to hit here is novel behavior of previously identified diseases, and my example is Ebola. We've known about Ebola since the 1970s. It's been causing outbreaks at least since then. But we are seeing more Ebola now and similar diseases and more significant outbreaks. And why is that? For the outbreak of Ebola in West Africa that happened starting in 2014, this was largely due to the introduction of the virus to impoverished and densely populated areas. Previously, Ebola outbreaks really occurred in remote parts of the world. They were a result of spillover events, we think from bats, maybe to primates, to humans. But these villages were largely isolated with relatively little travel to and from them, so it was possible to contain these outbreaks. However, once Ebola gets introduced into urban environments, there is much more transmission. This is due to crowding, and without the healthcare infrastructure to isolate and safely care for patients, that is what is concerning about Ebola. The outbreak that's occurring right now in the Democratic Republic of the Congo, or the DRC, has a slightly different dynamic in that there is active conflict, which has made it very difficult for public health and healthcare responders to get access to the areas, to treat patients safely, and to follow up on contacts of cases to make sure that the chain of transmission isn't continuing. Fortunately, with Ebola, we have a very effective vaccine that was recently developed and is being deployed in the DRC. However, we expect that we will continue to see these types of outbreaks, and both with Ebola and other diseases in cities and conflict zones. Future outbreaks with other viruses, for example, Nipah virus is one thing that we're concerned about. We don't have a vaccine right now, so we would face many of the same challenges that we faced early with the 2014 Ebola outbreak. The next topic is vector-borne diseases. In the 1970s in the Americas, we virtually were freed of what is called the Aedes aegypti mosquito, which is the vector that carries a number of important human diseases like yellow fever, dengue, chikungunya, and now the recently emerged Zika virus. Since the 1970s, there are a number of factors that have changed this. Reductions in the use of DDT. I'm sure many of you remember DDT. It was toxic, but very effective for reducing vector populations. Waning effectiveness of other pesticides is also contributing. A lot of it is defunding of vector control programs, particularly here in the US. There's just not a lot of resources to reduce these populations. And also changing climate and seasonality for these vectors. It has resulted in a resurgence of these and other vectors in the US and local spread of disease, which we didn't have before. You can see this map here. It looks at the 1930s, where the mosquito was widespread, 1970, once we almost eradicated it from the Americas, and then in 2001. You can see the spread is extensive again. And since that time, we've seen it expand across the United States. So in the last 5 years, we've seen the global emergence and spread of Zika virus. And we think this trend is going to continue, not just with these Aedes mosquitoes, but also other mosquitoes, Culex, ticks that carry Lyme disease, mosquitoes that carry things like West Nile. Depending on the geographic location of outbreaks, there can be significant illness associated with these outbreaks. Dengue spreads very efficiently in impoverished parts of South America, for example. In the US, we don't see as extensive spread, although in poor neighborhoods, particularly in the South, we expect to see more local transmission in the future. I wanted to talk about reestablishment of previously controlled diseases, and measles as an example. So, unfortunately, last year, the US almost lost its measles elimination status, its measles-free status, because there was sustained transmission of measles for almost 12 months in New York. Fortunately, public health officials were able to finally stop that transmission just under the mark. But there are other countries, particularly in Europe, that are seeing rates rise for many vaccine-preventable diseases. And many have lost their measles-free status as well. Because of the high transmissibility of measles, the high R0, which I said was about 18, up to 18, measles requires a very high vaccination rate in order to prevent spread. And unfortunately, vaccine hesitancy and vaccine denial are huge factors in this. And as long as that movement persists and laws in the US and elsewhere don't require parents to vaccinate, this trend is going to continue. And we'll see the return of some of these childhood diseases. And finally, I want to talk briefly about antimicrobial resistance. This is a huge problem for a wide range of bacterial diseases. It's brought on by decades of overprescription and overuse of antimicrobials as growth promoters in agricultural practice, not to treat disease, but to improve growth. And we're seeing the complete ineffectiveness of some antibiotics and multi-extensive or extensive drug resistance in some pathogens like tuberculosis. If this continues on this trend, there's a lot being done right now to combat this, but if it continues on this trend, we could be looking at a post-antibiotic age where you go in for a routine surgery, you get infected, and you aren't able to survive because of the infection itself. Some bright spots, some antibiotics are being preserved for last resort. There are alternatives to antibiotics, like phage therapies that are under investigation. But unfortunately, the pipeline for these new antibiotics and new approaches is pretty dry. So this is something that we see as a big danger, and we're not investing enough time and resources into addressing this problem. So I won't belabor this next slide because you all know this well, but I did want to mention that natural disasters with major public health impacts, they contribute to this environment of emergencies and outbreaks that we're seeing now. And it reduces the ability of public health professionals to be able to respond to traditional public health threats. For example, the U.S. Centers for Disease Control, their EOC used to stand up a few times a year on a restricted basis. They were able to shut down the EOC after they have responded, but now it pretty much runs 24/7, and they're always responding to multiple events. And so this is the trend that we're seeing, and it is exhausting the public health workforce. At the same time, we're often defunding public health and reducing their ability to respond. So it's a kind of confluence of events here. Okay, so that concludes the natural hazards that I wanted to talk to you about. Next, I'd like to address some accidental public health threats that we think should be on your radar. There are a number of types of threats. I'm going to focus on the first bullet here, accidental biological threats of greatest concern. But there's also non-biological technological accidents that we think would greatly affect public health, like a radiological release, a nuclear power disaster, and failure of aging infrastructure, which we've seen in the US in some cases. So I'll start with an accidental laboratory release of a natural biological agent. Laboratories are human operated. They're thus vulnerable to human mistakes. We can't make them 100% safe. Some laboratories work with pathogens that are natural, in that they're endemic to some parts of the world, but that would be of potentially high consequence if they were released from a laboratory. These labs are the facilities that are of greatest concern for accidental releases because the consequences would be so great if something were to happen. They're called Biosafety Level 4 facilities, or BSL-4, and they're important to facilitate research on these diseases. There's a reason that they exist. We want to better understand how to control them in an outbreak, and also to help develop drugs and vaccines against them. But for these facilities, in the US, they're highly regulated, very safe, great biosafety practices. That's not necessarily true around the world. There is not an international standard for biosafety and biosecurity. I know a lot of professionals in the US government are working on this to address this issue, but these labs are expanding worldwide on every continent, and so it's something to keep in mind that we should be developing these international standards. A related topic is laboratory accidents related to what's called gain-of-function research. This is a category of research where pathogens are engineered to have different characteristics or functions. This could be infectivity, it could infect different species, increased transmissibility, or increased severity. And that sounds strange that you would want to do that for a pathogen. But the purpose of doing this research is intended for public health benefit. It's to understand, once again, those pathogens, to understand under what conditions they would be made more transmissible or more severe, and how to recognize those through surveillance so we can stop an outbreak from happening. And also, it informs the development of interventions, drugs, and vaccines. But there's a big debate that happens in our field about the wisdom of these experiments and whether they actually do inform public health action on the ground. I think there's a little bit of a gap between the science that's being done and the public health impact. If something were to happen and one of these gain-of-function pathogens were released, there is a possibility of huge consequences. So it's something that people are thinking very carefully about how to regulate this type of research. You may have heard the term DIY biology, DIY bio, or do-it-yourself biology. This is an emerging and largely benign trend. It's really citizen science. It's people in community labs. They're intended to promote learning, creativity, and fun for both kids and adults. They do fun experiments. Like I said, it's largely benign. It's a really interesting movement. But as tools for biological manipulation advance and democratization of these tools, making them easy to use by people that are not experts in the laboratory, may increase the possibility of an accidental creation of something serious. This is a very low probability event, but I wanted to bring it up because I'm sure you've heard the term bandied around. The FBI actually has been concerned about this and has been being very proactive in reaching out to these community laboratories and working with them to develop guidelines, safety protocols, approaches to reporting something if you see something that went wrong. So that is all very positive. A final thing that I wanted to point out here is the unintended consequences of gene editing. So we've seen the ability to edit genetic codes change. It's much more easy and accurate. You've probably heard of CRISPR. This is one technique that's used to edit genomes. It has yielded huge potential benefits for medicine, public health, the economy, but there are also risks as well. So the example I wanted to give you is gene drives. Gene drives are a recently developed method that makes edits to a genome that will self-propagate from generation to generation in an organism through sexual reproduction. So one example of this, the benefit of this technology is the ability to reduce disease transmission by mosquitoes. So a mosquito is genetically engineered not to be able to transmit malaria, and then it's released into the wild. It propagates. Its offspring also cannot transmit malaria. So there's huge potential benefits here. But once these gene drives are released into the wild, they're difficult to control. As I mentioned, they will expand exponentially, potentially. And we don't know right now if we can fully predict what will happen. You all know that ecologies are very complex. We've seen examples in the past of meddling with ecologies that can go very wrong. I'm not necessarily saying that that will happen with gene drives, but it's a possibility that altering the mosquito to prevent transmission of malaria may have some unforeseen downstream impacts. So what scientists and policymakers are weighing now is what are the potential benefits versus the possible consequences, and how can these things be tested in safe environments to see how they actually roll out. So this last section, I will focus a little bit on intentional use of CBRN weapons. I won't belabor this because I think that you all know this topic fairly well. Since 2001, I think we've seen a return to interest in CBRN weapons generally. Despite international norms and treaties against their development and use, we have evidence now of state offensive chemical and biological weapons programs and interest by non-state actors. So recent examples of chemical, biological, and radiological weapons use. You all are familiar, I'm sure, with the 2001 anthrax attacks in the US. We've had a lot of recent chemical weapons use, obviously in Syria. The binary chemical weapon that was used to assassinate Kim Jong-nam by Kim Jong-un, his cousin. The use of Novichok nerve agent to assassinate Sergei Skripal with collateral damage to his daughter and to other people. And then use of polonium-210 as an assassination weapon against Alexander Litvinenko. So these are just a few examples of what's been done in the recent past. For potential future scenarios, we think CBRN use in warfare or terrorism is possible. This could be manifest in the use of an existing CBR agent of concern, an intentional release of a genetically engineered pathogen that we don't currently know about, or another example, I haven't focused on the nexus of public health and animal health, but agricultural attacks used to cause severe economic disruption or eradication of major food sources. So based on all of this, I'll just touch briefly on what are some of the public health practices and policies that we need to focus on in order to mitigate some of the impacts of these threats and possibly reduce them altogether. You all know very well education, training, and exercising. The reason I add this in here is this is an event, a high-level policy exercise, tabletop exercise that my colleagues and I put on back in October. It's brought together high-level leaders in public health, national governments, and private industry to try and discuss some of the major implications of a pandemic. To illustrate the value of this, our team actually chose a novel coronavirus as the agent to use for this scenario. And we were asking a lot of the questions that are coming up now in this outbreak that we're seeing in China. So that's both good and bad. We didn't have a whole lot of time to act on some of the recommendations that came out of that exercise. But I do think they're really valuable in raising these questions at many levels. So ours was at the high political level, but obviously they're useful at every level. And then what are some other interventions that we've been focused on? You all probably are very familiar with horizon scanning. The public health profession is not. We tend to not be very forward-looking to future threats, but our proposal is that we need more horizon scanning, both for threats and opportunities for investment to try and address those threats. Next, we need to be building a flexible medical countermeasures response. That's drugs and vaccines. Right now, up to this point, we've never rolled out a vaccine in under a year, with the only exception is a strain change for influenza. And so the goal is to be able to discover a vaccine and get it into people's arms within a couple of months. To do it in time to affect the outcomes of an emerging epidemic like we're seeing now. And scientists are working on this currently for the novel coronavirus, but the estimates are 9 months to a year, and that is if we have an effective vaccine that is discovered. What we need to be doing is investing in platform technologies that we know work well, approaches to developing vaccines, and you can switch out different strains, different viruses. And then on top of that, we need to be investing in scalable manufacturing. One of the big choke points in developing a vaccine, even if we had it now for this coronavirus, is how do we scale up that manufacturing and get it to people who need it? We don't have good plans and protocols on how to do that. We also need thoughtful work to identify and integrate new technologies into public health practice. Public health is notoriously slow in adopting new technologies, but we're seeing some really interesting stuff right now. Wearables that can take your pulse, maybe your temperature eventually, drones that can deliver medical countermeasures to your door, novel diagnostics that you could use in the field that are paper-based, that can tell you an answer within minutes. These are all things that they're not far-fetched. These are in development or in wide use already, but not adopted by public health on a wide scale. And so this is something that we need to work on. We need a fund for public health emergency response. Obviously, there is a fund that we've had for a long time for disaster response in the United States, but we don't have a comparable fund for infectious disease emergencies. During Zika and Ebola, you maybe remember that we had to wait months for Congress to actually approve emergency appropriations for public health response. And in that time, we're diverting resources, diverting funds, diverting people from their normal duties to deliver healthcare and public health. So this is something that's really needed. We need more coordination of health security at the top levels of government, here and elsewhere in the world. In the past, actually with every president, there is usually a spot in the National Security Council for public health. When a president comes in, they say, public health, that's not security related, get him out of here. And usually within their tenure, then there's a public health emergency, there's an infectious disease emergency, and public health is invited back into the NSC. And so we need a more secure spot within that organization in order to manage across government these types of emergencies. We also need to better identify gaps in our response capacity. So right now, as I mentioned before, we're seeing a lot of problems with supply chains. We're going to see problems with workforce. These are not things that we traditionally focus on in public health. And so we need to work in non-emergency periods as we can to improve these and arrange for coordination across sectors, not just within government. And finally, we need to think about how to integrate non-traditional assets into response. The Medical Reserve Corps is an interesting asset that can be available to expand surge capacity in the healthcare system. DoD obviously has many assets and supplies that could be brought to bear in a severe emergency, and the private sector as well. And that coordination is not necessarily optimal at the moment. So those are my calls to action. I think I'll stop there. And my question for you all, I think to address at your tables, is of these things, and there's a broad array of different threats, what concerns you most? Thank you. I have not heard that specifically, although I know there has, we've been leaning that way in a little bit. What I've heard from the CDC is that once there is evidence of sustained transmission, that the travel ban will be lifted. That was the original sentiment, that was the original statement. We have evidence of sustained transmission outside of China in multiple countries, so I'm not sure that I'm not sure they're going to follow through on that, but I don't know about additional travel bans. I think it would be unwise to do that and ineffective. But I hope that is not the way we're going. The general degradation of the public health workforce, specifically around preparedness, and the healthcare workforce is really the problem. And so what we need is sustained annual funding to support preparedness work. We also need, I think, that emergency fund that can be there and ready to move as soon as we see something happening. And we also need Congress to be able to act quickly to appropriate additional resources. We have investment in working on development of drugs and vaccines, but it's not enough. And what we really need to focus on, we've been focused one bug, one drug for a very long time. And what we really need to focus on now is developing platform technologies, novel technologies, nucleic acid vaccines, for example, that could be not only developed quickly, but then also manufactured and rolled out quickly. But it all hinges on funding support, and we really haven't seen that. And we've seen in the recent budget a degradation of a lot of the programs that support public health response. Yeah, I think by and large there are some real bright spots, especially compared to SARS in 2004, where there was a 3-month delay before they even let the international community know that there was something happening. So this was a couple of weeks into this outbreak when they announced it internationally. And I do think that by and large there's been a good faith effort to report cases and deaths from this disease. That being said, this is a very chaotic situation there, and I think there are major limitations with testing, with identifying cases, especially in the midst of a severe flu season, with RSV also circulating. So that complicates things. I'm sure there are other factors as well. There may be cases that weren't counted that should have been, but I think by and large they have been pretty forward-leaning in reporting cases. That's a good question. That's a hard question, though. I don't know enough. I'm not a vaccinologist. I'm not a virologist. So I'm not sure what the probability of a success there is, but I do think it's the right idea and it's the right approach, and we should be pursuing that above other priorities right now, not just universal flu, but other platforms as well. Quarantine is useful in certain cases, in maybe small groups of people that have been exposed. We don't know if they're infected. It is an important public health tool that we need to preserve. But this mass quarantine of entire cities, even entire building complexes, we saw in SARS that people quarantine even just a single building. They ran away. They were able to evade the quarantine. People get frightened. They want to be able to access healthcare. It just is not effective because of human behavior. I do think it's natural to want to use measures like this, especially travel bans. If we can stop people traveling from China to the US, intuitively that makes sense. The problem is it's not sustainable. How long are we going to maintain these travel bans? Once we restart travel, this is going to spread. I think there are a lot of other downstream impacts of travel bans that are really negative, and we have to weigh what those are against the benefits. And I see the benefits as being fairly low at this point with the behavior of this virus. So some things that we can and should be doing are isolating sick people, making sure that they're cared for safely, giving people information about what they can do to protect themselves, having people stay away from other people who are sick. Perhaps if it spreads widely in the US, maybe canceling public gatherings at the peak of an outbreak. There are lots of tools that we can use that I think will be more effective in limiting sickness and death than those kind of really blanket quarantines and travel bans. We're seeing on the Diamond Princess ship right now that was quarantined off the coast of Japan is an example of this. I think it was really unwise to keep all of those people together on the ship. They should have been taken off. They should have been in self-quarantine, and they should have been cared for. When you keep people together like that, if there are infected people, they're going to spread the virus. It's going to be much easier. And we've seen an enormous amount of spread on that ship and now 2 deaths. So I think that's a really unfortunate outcome of that public health measure. So there's not a vaccine now. In the US, the investigators with NIH funding in particular who are expert in coronavirus, are working on trying to discover a vaccine. We do have some capacity in the US. We've built some manufacturing capacity for novel vaccines for emergencies. So we do have some of that, but largely for our traditional vaccines, the manufacturing is located not in the US. It's mainly, for many vaccines, it's in Europe actually, some in China, but I do think that should be a priority of the US government, is to have manufacturing capacity located here for these types of events. Yeah, for flu, it's changed a little bit. So the ASPR and HHS has worked on creating more manufacturing capacity here. It's not going to be a total game changer. We don't have enough. And there are a couple of manufacturers now that do produce in the US, but the picture is largely the same. And one thing we haven't done with flu vaccine is switched from our traditional egg-based manufacturing method, which is pretty fragile, to a cell-based approach. And that's because it's expensive and vaccine producers don't have the incentives to do that. So largely, I think the picture is the same there. One thing that we can do, and one thing we did do in our exercise that I showed you the pictures of, was to bring these companies to the table to have these discussions. Largely, they are left out of discussions about response to these types of emergencies. And so even just making them aware of what the issues are is a really good first step. I think the government is trying to figure that out right now. So for developing drugs and vaccines, there are incentives. We've worked for a couple of decades now to try and develop incentives and processes to get over what's called the valley of death for vaccines, to make sure that we can have them when we need them. But we haven't put the same attention to these manufacturers for general medical supplies. And so I saw a tweet, I think this morning, from a medical supply company that makes masks that ramped up production for the 2001 H1N1 pandemic. And once they had done that, they're not doing it for this epidemic, because once they did that, the government, everyone forgot about them as soon as they ramped up production, and they were left holding the bag, and they had to lay off 100 people. So we need to figure out how to not let that happen, but I don't think there's been a lot of serious thinking on that so far. Our link to the CDC is in an advisory capacity largely. So our director is on a number of advisory committees to the CDC, and they call him up and convene groups when something like this happens. We also do some research for CDC, more operational research. Specifically, we've done work around Zika and Ebola. But we are there should they need us to call upon us, and we offer advice. So the outbreak in the DRC, we're seeing some good news about right now. There have been very few cases reported in February, so I think it's finally coming under control, but there have been thousands of cases and many deaths so far. I think There are a number of big problems there. It's access to people to actually uncover disease and treat them. There's the trust in the responders and in the government that is very low, so people don't want to present for care. There's also the danger to the responders that have been going on. We've seen a number of healthcare worker deaths in this outbreak. And then there are just human behaviors about movement of people that may actually create environments that spread the disease. So I do think these are all factors that could happen in other outbreaks as well in conflict zones. We have a very long history of use of biological weapons. Obviously, we have the 2001 anthrax attacks. If you're referring specifically to kind of taking something from the Ebola outbreak, there was an attempt, I believe in Nigeria, someone took samples of the virus and was intending to spread it to their relatives in Nigeria. So there are one-off examples like that. We do have other examples in history. Shinrikyo is one that attempted to use anthrax in addition to chemical weapons. Fortunately, that was a vaccine strain, so it was ineffective. But I do think we have a long list of examples of people wanting to do that and attempting it. I actually worked for DHS previously. I worked in science and technology on the Integrated Terrorism Risk Assessment Program, and so that's one approach to risk assessment. It's highly quantitative that I have used in the past and our center has used. We also do elicitations of experts to try and understand what their priorities are. We've used Delphi studies to try and understand what people's concerns are. So those are the types of methods that we've used. I think for the US, I think we need a broader approach to understanding risks associated with biological events. At DHS, focusing on terrorism risk assessment is currently what we're doing, but there are, as you can see, there's a range of other threats that I think we should be assessing together, and we currently don't do that in the US. Some other countries are very good at that. The UK, for example, Canada does a good national risk assessment. Yeah, so one thing we need to be doing right now is looking for those cases. Right now, we're not. We're only looking for the people who become ill, have known contacts with cases, become ill, are hospitalized. In the US, our protocol for testing right now is if you have a link to Wuhan, China, then you will be, and you're sick, have some symptoms, you will be tested. Or if you come from China more broadly, if you are seriously ill enough to be hospitalized, then you would be tested. No one else is getting tested right now. One thing the US is going to roll out, hopefully, are some sentinel sites across the US to try and understand, look within at least hospitalized populations to see if there's disease there that we're not recognizing. So that's the first thing that we need to do. The good news is if people are spreading this asymptomatically or with mild symptoms, that means that this is not as bad as it looks in China right now. And so if that's the case, this could be more akin to a cold. There are other coronaviruses that circulate regularly in populations, and it causes common colds. So we can be hopeful that that is the case. And if that is true, then we can't stop it because it will be very contagious, but we can stop worrying as much about the severity.